Okay, so I'm here today with Dr. Mark Brennan-Ing, who is the Director of Research and Evaluation at Brookdale Center for Healthy Aging at Hunter College, City University of New York. Did I get that all?
That's perfect, Megan.
All right. Mark, thank you for being here today. Mark and I have worked together on a few things, but sort of also share an interest in sexuality, sexual expression in later life, and LGBTQ, older adults, and how those are confluenced. And Mark also specifically works on HIV and aging, which he has done across his career in many different spaces. And we're going to talk today about how he got into this work, what he does, and some questions about older adults with HIV. So, Mark, why don't we start off by you telling me what you do and how it relates to aging?
Okay. Well, at the Brookdale Center for Healthy Aging, you might imagine that most of our work is focused on aging. And indeed, we are very focused on developing policy both at a local level, but also statewide and nationally, and even internationally.
Cool.
To achieve what we say our tagline is, so that everybody can age as well as anyone can. So we're very concerned with vulnerable older adults who may not have the same privileges and opportunities as other older adults. That ranges from the two populations I study a lot: older LGBTQ adults and older adults with HIV, but we're also concerned with people who are racial or ethnic minorities, immigrants, people of lower socioeconomic position, any of those things that could prevent you from achieving a good old age. I won't even say successful aging because that's such a charged term. So a lot of my colleagues focus specifically on policy issues. My job is really, as an applied researcher, is to develop the kind of research that can inform policy. And I actually find myself, because I work in the sexual and gender minority space, as well as the HIV and aging space, spending a lot of my time working on policy and advocacy issues around those populations. But we're not really limited to that. So for example, one of the projects we're doing now is a systematic review that looks at cumulative disadvantage and advantage over the life course. And if you're not familiar with that term or that theory, it's really the idea that the rich get richer and the poor get poorer, and this stuff piles up over a lifetime. So we're doing a systematic review of the literature to see what points in the lifespan would be good for intervention and what areas would be good for intervention. Because by the time someone gets into late adulthood and old age, it's kind of too late to stop that process. You can support those people, but what we're looking for is, how do you intervene along the life course so that people end up in old age kind of in the same playing field? One example of this is the impact of incarceration. Both in terms of in your family, if your parents or a close family member is incarcerated, or if you're incarcerated yourself, that kind of has a long ripple effect along the life course. So my job in aging is to develop and execute different research projects that address this basic idea of what's the research we need to develop policy to support people who are aging in New York City and elsewhere.
Very cool. Mark, can you give us an example of something that you've either done or that you're doing in the LGBTQ and aging space that has either led to policy, or where you're headed with the work in terms of what you hope to impact?
Sure. So there's a couple of areas, but there was a study we did of LGBTQ older adults in Chicago uh, that I thought it was a mixed method study, and I thought it really did a lot to break down these stereotypes
Mm,
of kind of this A-list, white, wealthy white gay man
mm.
stereotype that we have if, too many people have watched Queer Eye for the Straight Guy or something like that,
Yeah.
or Millionaire Listing or whatever, this idea that, gay people live these, happy, financially secure, carefree lives.
Mm,
Um, what we really found when we talked to older sexual and gender minority adults was that they had a lot of unmet needs. A lot of
mm,
them were socially isolated. A lot of them were struggling economically, having trouble so think this is kind of the generation ahead of me,
mhm.
kind of that Stonewall generation, when even though there's still a lot for us to do today, we've come a long way. And for that generation, you could be fired, lose your housing, be
Yep.
ostracized if people found out your sexual or gender identity. And that constrained a lot of people economically and educationally, so that they may not have had a job that offered a pension, or their employment history may have been a little more turbulent, and they find themselves in later life without the kind of economic security that a lot of people have,
Yeah.
and struggling for their basic needs, including around housing. So this I thought it was really an important study to kind of shed light on that. And the qualitative portion of the study, um, I think really, I hate to use the phrase gave a voice, but helped us to understand people a little more. Like I
Yeah.
remember one quote from it was an older trans woman, I believe, who said she had been applying for all these jobs
Mm,
and she was eminently qualified to do them and would never even get a call back.
mm,
Which is very emblematic of the difficulty that a lot of trans and gender expansive people have
mhm.
in terms of finding employment. Housing was another big one, and actually there was a real connection between our findings there and some policy and programs that came out of that. So
Hmm,
we had done this study at the Center on Halsted in Chicago, which is the big LGBTQ community center there.
hmm,
And after we completed the study and we had this data about the housing problems, and I wasn't involved in this part, but the Center on Halsted and, oh gosh, I can't remember the name of their partner there, but developed one of the first senior housing buildings for older LGBTQ people in the country. This was going on 10 years ago now. And the really
wow.
neat thing about it was they built it adjacent to the Center on Halsted building. So there was that
Okay.
ability to integrate social services, and um, the Center on Halsted also has a community space on the ground floor,
Mm,
which a lot of people use. So it was really, really a nice project. And I think the demonstration that something like this could work and was viable has helped to support the expansion of these kind of programs all around the country. Sage Services and Advocacy for GLBT Elders,
yep.
which is based in New York, has opened at least one residence, and they're working on a few more. I know there's some in LA and San Francisco. So um, I get, as a researcher, it's really gratifying to me that the research that I do can contribute even in a small way to fostering positive change in people's lives. That's for me the reason I get up in the morning and do this kind of work. It's not really to publish another paper or present at another conference, and all of that's really good. Um, but I think when you can do research that can have a direct benefit to people's lives. That's an important thing.
Yeah, I hear you, Mark. That's something that I've always felt like is, I don't know if it's unique to like us aging folk, but it feels like that's sort of a lot, a kindred aging spirit kind of thing. And I don't know, maybe it goes along with seeing a lot of deficit areas, like there's a lot of work to do. So it's really helpful to know that the next thing that you can do could make a really big difference to people who really need it, who really need it. And that rings true to me. How have you seen aging change in New York City in your space, since you've been doing your work, or have you, for LGBTQ and in general?
Mm. Um, so in general, unfortunately, I would say things have not changed all that much.
Mm-hmm.
I one of the first big things I worked on was a study of older New Yorkers called Growing Older in New York City in the 1990s.
Mm-hmm.
And based on the results of that, there was a lot of talk about the senior center of the future, and how we could reinvent aging services in New York City, with the idea that and unfortunately still a lot of senior centers are primarily a nutrition program for
Mm,
low income people, and they don't really engage more middle class people, um, and don't really deliver in terms of their promise of being a center for education, for
mm-hmm.
recreation, or for socialization in general. And this isn't to say that the senior centers don't do a lot of great work, but within the past year, the Department for the Aging here released a RFP, request for proposals, around still inventing the senior center of the future. Um, of course, I think the experience of the COVID pandemic might move that along a little
Yeah.
bit, because it really threw service providers back on their heels. When you have programs that are so high touch in-person kind of programs, and how do you translate those to more remote things, and what do you do about access to technology,
Yes.
because the populations that senior centers primarily serve are also the older adults who have the most barriers to using technology. And that's actually a focus of my colleagues at Brookdale, about
Oh,
increasing
cool.
technology access. And a project I'm working on where we're going to evaluate some technology enhancement programs that a major service provider in the city, JASA, Jewish Association for Services for the Aging, did at some of their residences and programs.
Hmm.
Um, so that has yet to be realized. I think where things have changed in a good direction is recognizing the diversity of older adults and trying to tailor um, programs that are more accessible and friendly for them. And the two that I think of off the top of my mind have to do with research that I've done, not surprisingly. Before I got into the HIV and the sexual and gender minority work, I studied how people cope and adapt to visual impairment and
Oh, yeah.
dual impairment of vision and hearing. And a few years ago, I can't remember if it was the current mayor or the one before that, but the Department for the Aging developed some specific senior centers for people who are visually impaired,
Very cool.
and also did that for LGBTQ adults. So Sage had been running their own program for quite a while, and that got folded in now to, kind of the official senior centers. Uh, which was challenging, but now they've opened some more of these, and outside of Manhattan and the outer boroughs. So um, yeah, I do see progress in that way. Um, I don't know really how much. What I'd like to see though is more integration of that in every senior center.
Hmm.
So that it wasn't just a specialized place you had to go. Sage has a great program. The one I'm most familiar with here in Manhattan, in the Chelsea neighborhood, but not everybody can get there,
Yeah.
because one of the issues we face when we get older is lack of mobility in terms of physical limitations, but that can also translate into lack of accessibility, since in New York we rely so much on public transportation.
Yeah.
Especially working class and middle class people. You can't take a cab everywhere, especially now because the prices have gone sky high after the pandemic.
Hmm.
So the more that we could diffuse that program, to me a great place to be would be where a LGBTQ person would feel comfortable going to any senior center
Yeah,
and
absolutely.
being able to access services there. So some progress. I guess I'm impatient about it and
Yeah.
would like to see more, but
Yeah. Yeah.
um
I think
that's been good. Yeah, I mean, and they have also worked on the transportation issue. There was a program, still is a program, it's called Accessoride. It used to be a van service that the Department for the Aging arranged, where you would call up and be
hmm.
picked up and dropped off. And uh, the complaint was that it was inconvenient. You had to kind of go by their schedule, and um, also that you'd wait a long time,
Hmm.
for a pickup or a drop off, and vice versa. So they've now kind of transitioned that to a voucher system using public transportation like cabs and things, but there are still some issues with that in
Yeah.
terms of it's increased the number of rides that are available, but the people who are doing these pickups don't necessarily have the training. So, an example,
Yes.
it was actually one of my husband's patients with Parkinson's who was waiting for a pickup, and the guy has a lot of mobility issues. And the car came and it stopped halfway down the block, and was expecting the guy to walk there, which kind of defeats the purpose of that.
Yes.
So,
I think that that's really important though when we think about like we're encouraging each other in this class to think about all of the different ways in which advantage and disadvantage accumulate. And when
mhm,
you think about urban older adults, it's such a different population than I don't know a lot of people may be exposed to. Not a lot of folk grow up, and age into urban
mhm,
spaces, but it brings up a lot of unique issues, and transportation is an issue everywhere, but access to social connection and the important things that builds for wellness and physical wellness and
mhm,
being able to like move around in spaces with other people, it's all like tied into each other. And infrastructure, right? This is one of the things that makes policy so important, is that infrastructure literally makes this happen or doesn't. So,
mhm.
you know, we definitely need people like yourself, to inform the people who are making decisions to say, probably not the best to have a non-trained cab driver,
Yeah.
pull up down the block. Maybe we need some sensitivity, some age training for transportation folk. That would be a great job for somebody.
Well, I think you bring up a larger issue in that, now I'm trying to remember where I saw this, but oh, actually in New York City, there's a push now to kind of integrate aging training more broadly across the various city agencies rather
Mm,
than just in the Department of the Aging. So if you have somebody in the, housing authority or one of the myriad New York City offices, and they're dealing with an older adult, they have some awareness and some sensitivity about, what
mhm.
some of the issues might be.
Yeah, I think that's key. We talk about that a lot with, law enforcement and, with increased risk for dementia across age comes increased risk for a lot of things that look very strange and can be misunderstood, et cetera. And helping someone with dementia navigate back to a space or
Mhm.
understand where they've been. And, certainly when we talk about elder mistreatment and things like that and how to handle those kinds of calls, it's a huge deal. But I digress. Mark, I would be remiss if I didn't ask you about your work with HIV and aging. It's like ridiculously well known and like really, I think, pivotal to our understanding of how people have been aging with HIV. And this is a big group of folk and cohorts who are very unique. So
Mhm.
tell us what you're doing now in that space.
Okay. So one thing people should know about me as a researcher is I've been one of these generalist types, and I don't have a lot of people in research have a very, very narrow focus, like, the anterior ganglia and the aging primate or something like that. And I think, as you know, my work's been all over the place, from social gerontology to some of the work around sexual health that we've collaborated on, mental health and well-being, resilience. Uh, so there's my current work is kind of split. I'm working on two projects now that have a very much a medical focus,
Mhm.
but are very germane to aging with HIV. One is looking at antiretroviral forgiveness. So antiretrovirals are the medications that keep HIV in check. They're not a cure. They
Mhm.
do a really great job at controlling the virus, but you need to be adherent to them for them to work. So this is a secondary analysis of some health insurance claims data, and
Mm.
we're looking at how adherent you need to be to those medications and whether the type of medication you're on affects your ability to be virally suppressed.
Mm.
So that's the gold standard of HIV care, is to get the HIV virus down to a level where it's not detectable in your blood. And not only is that good for your health, but it's very important in terms of public health, because people with an undetectable viral load can virtually, it's impossible for them to pass on the virus through sex.
Yep.
Um, so if we get enough people with HIV virally suppressed, well, we're hoping that the epidemic will eventually kind of collapse. Now, the population in New York with HIV is like the population in the US and a lot of Western countries. Half of them are over the age of 50, which is what we consider an older person with HIV. And so then you start dealing with typical aging issues, one being multimorbidity or having multiple chronic conditions. We find that people with HIV have on average about 3 chronic conditions in addition to HIV. And then if you think of treating the HIV and these comorbid conditions, then you have the situation of polypharmacy or taking 5 or more medications. And then there's all kinds of potential for drug and drug interactions. We also don't really have a good understanding of the long-term effects of antiretroviral therapy on people.
Yeah.
The older people with HIV now are really the first generation to have been taking these medications now for 20, 30 years almost, thank goodness. Um, so in that study, we're looking at, how multimorbidity might affect that, and how polypharmacy might
Cool.
affect that. Um, and we had done kind of a preliminary study that shows that people with unsuppressed viral load are actually sicker.
Mm.
And it's not really clear if that's because they're not suppressing the HIV virus. It's probably related to that, or that the unsuppressed viral load is just part of a syndrome of poor health we see in people getting older.
Mm.
So we're hoping to untangle some of that with the next study. Um, And so then on the other side of that, I'm working on a study called Patterns of Healthy Aging in Men Who Have Sex with Men. I'm a co-investigator on that, which is part of the multi-center AIDS cohort study, WICE, which is the Women's Health Interagency Study, combined cohorts. So these two cohort studies have been following people with HIV since the 1980s.
Whoa.
And they have both people with HIV as well as people at risk for HIV. So you have some good comparator groups there.
Yeah.
And so in that study, I just had one paper published where I was looking at how psychological connection to the gay community
Hmm.
affected negative self-appraisals around body image and aging in sexual minority men. Um, and whether being engaged in fitness, both psychologically as well as being physically active, had a mediating effect on that.
Hmm.
And I got interested in that because there's been a lot of anecdotal studies or anecdotal talk and some studies that have pointed to this ageism in the LGBTQ community and how that could be harmful in terms of psychological health. In fact, one paper by White that was done out in California described this as kind of a psychological accelerated aging
Hmm.
in older gay men. Um, Plus, I've heard a lot about it from friends and everything. So I did the study, and I had hypothesized that if you felt a greater connection to the community, um, you would actually have more negative self-appraisals, be less satisfied with your body, have negative attitudes toward aging.
Hmm.
And I'm really happy to say that not only was my hypothesis not supported, it was the exact opposite, that having that kind of psychological and emotional connection was protective against those negative appraisals.
Very nice.
Um, and also it promoted the fitness engagement
Oh,
piece of
yeah.
it too. So not only was it protective psychologically, but it also was associated with behaviors we know that help keep you healthier. Um,
Awesome.
so I was really happy that that one didn't work out, and I had a positive message to share. And really, it's really in line with what we know about social support in late adulthood and how important that can be. Um,
Mhm.
Not just the support that you actually receive, but perceiving that that support is there and available really helps people to cope and adapt with things that may challenge them as they get older. Uh,
Absolutely. I think that that's awesome. And I like secretly was hoping that that would be the case for your results because it does kind of tie into that idea of the connections are regardless of to what like sort of, I mean, there's probably a limit here, but the
mhm,
cultural norms that are in that group, it might be more just about having an identity and a home for that and people to share those things with, as opposed to like having a heightened sense of beauty ideal or
mhm.
something like that. Like it's still protective, which is good.
Yeah, that's kind of the conclusion we came to, in that while ageism probably exists as it exists in many places in our society, that the positive benefits of that engagement outweighed it.
Hmm.
Um, and I think it might also speak to something I wasn't really able to look at in a cross-sectional study, um, but this came out in some discussions I was having with colleagues, was really, you know, as we get older, do we have different standards about how we look and coming to accept aging? And
Hmm.
I guess a certain maturity there that was unexpected.
Yeah,
Um, a 60-year-old person goes to the gym for a lot different reasons than a 20-year-old does often,
absolutely.
and it becomes less about trying to have some beautiful body, and it becomes more about maintaining your health.
Hmm.
And um, so yeah, I was very happy with that. I'm working on a follow-up paper now looking at how these negative self-appraisals are related to other forms of psychological distress like depression and anxiety, and what might mediate and
Yeah,
help resolve that. So stay tuned.
that's right. I'm looking forward to it. So, given the work that you do in the spaces that you're in and aging, what do you see as some of the biggest challenges for older adults right now?
Oh, well, this is a, to the extent I've been working on COVID related issues,
Mhm.
which hasn't been a formal research project. Um, my big concern for older adults right now, kind of largely defined, is the impact of the pandemic.
Mhm.
Um, because we had to do all this social distancing, and of course there's a technology to kind of overcome that. um but it's really increased social isolation for people,
Mhm.
and there's so much evidence out there that social isolation and loneliness in and of themselves have a negative impact on people's health.
Mhm.
And anecdotally, I've been hearing of a lot of older adults who are in a worse state now than they were pre-pandemic, and a
Mhm.
lot of that may be due to the isolation. Even in this apartment building, I live here in New York. We lost a number of older people, and not to COVID,
Mm.
but other health conditions that maybe they weren't, because they were isolating, maybe they weren't taken care of.
Mhm.
And other older adults that I know personally, or friends of mine talk about, have really kind of gone through a decline during this period. I'm sure my mother wouldn't mind me talking about her now. But before the pandemic, she was living in her house independently. She was still driving. Um, she would go to the gym 4 or 5 times a week. She was involved with her church. She would see friends, and all of that came to a stop.
Mm.
And fortunately for her, I have 3 sisters who live in the area near her, and they were, in contact a lot and helping her out. But it's just not the same as socializing with
Yeah.
friends. And I don't think this has been good for her. I know she had a lot of anxiety. Um, Long story short, she's stopped driving back in the fall. Within the last couple of months, she moved out of her house and moved into a independent living apartment.
Mm. Mhm.
Um, and it's been challenging making new friends when everyone's still wearing a mask,
Yeah.
because
Yeah.
there's an assisted living attached to the independent living, so it's all considered healthcare facility, and they all have to wear
Oh,
masks all the
yeah.
time. And that's difficult. I'm really hoping, though, that as things calm down, um, it's going to be a good opportunity for her to make more friends,
Yeah.
because now she's living on a floor with other apartments and has to go through the building, and she's a naturally social and friendly person. So I'm hoping that the net effect of this will be to increase her social network. And
Yeah. Yeah, but I agree that this in general, like the pandemic in general, has disrupted a lot of those networks that we as, you know, just generally people, but older adults themselves relied on for a lot of resources, including social connection, but also like tangible resources,
mhm.
that they needed. So I think yes, we're going to have to rebuild a lot of those things, but I like that you guys are working on the technology piece too, and I think more folks could use that. And because we do have this like reliance on it when things go wrong, and then we forget that it's not accessible, usable, easy for everybody, and that's often the most at risk who don't get access to it.
Right. Like we talk about telehealth, and I think, so that to me is one of the positives, is there's more acceptance of it. Providers
Mhm.
can be reimbursed for it. In a lot of scenarios, it makes a lot of sense. Especially, if we go back to the mobility issues, maybe an older person doesn't need to be in person at the physician every time
Yeah,
something comes up, right? Or for, say, a counseling session or something like that might make it more accessible. But if people can't use the technology, that's just not an option for them.
absolutely. I remember maybe mid-pandemic, a lot of action on the 20 and 12-2 listservs about um, Medicare, well, CMS, because it would have gone Medicaid too, but approving phone only appointments because, there were a lot of older patients and people without, video cameras that couldn't do like the reimbursable
Hmm.
telehealth. So, but they did get there. So we can adapt as a society and our policies can change quickly to help do that, which is good. Well, Mark, I have one last question for you, which is probably the biggest one here.
Okay.
um, we're seeking knowledge about age liberation in my class. So we talk a lot about the structures that uphold ageism and the ways in which ageism happens at different levels and among individuals inside yourself, but it's all held up by this sort of ageist society. So, if we were liberated in some way from those things, how do you think it would change your work if we achieved some level of age liberation?
I think it would change it a lot, at least in terms of shifting the issues, because I think
Mhm.
one big issue for older people in general, and then for, we talk about sexual and gender minorities or older people with HIV, is this invisibility.
Mhm.
Um, People just aren't aware or don't think about other older people. For example, in HIV, it's very, very pronounced. Um, there's still this idea that HIV is the disease of young gay men,
Mhm.
and kind of ignoring that, say, in like New York City, um, at least in terms of older adults, about two-thirds of them are heterosexual, women or men. Um, and there just aren't the kinds of programs or things put in place to
Yeah.
really address them. I did a qualitative study, and this was actually an older heterosexual guy, and he's talking about going to some program at an AIDS service organization, and he got in there, and it was all like teenagers and early 20s, and someone said, "Oh, we got a grandpa," and he never went back to the program.
Yeah.
Um, Things like that. But also that invisibility affects policy,
Yes.
because if you're invisible in society, you tend to be invisible to policymakers. So they're really not thinking of how to address the needs of older adults. One of the things I want to point out with these populations, their needs largely mirror the needs of older adults without HIV, older heterosexual and cisgender adults,
Mhm.
um, but they can't access the same kind of programs. So in some way, I think as a society, we put too much of an emphasis on age. Like, to use older Americans Act programs, you need to be, I think it's 60, 62 or older. But there are a lot of people in their 50s who could benefit from those programs, as well as people in their 40s. But
Mhm.
we've placed this age restriction
Hmm.
and made age segregated programs,
Yeah.
for what we consider older people with HIV. Their median age in the US right now is still like 58 or 59. So, more
Yeah.
than half of them cannot access those programs, which they could really use. Um,
Hmm.
I think also, part of it is cultural, and, what kind of images do we see around older adults portrayed, say, in media,
Yeah.
film, television? um, are they positive or are they negative? One, so here's an example I think you'll like, and you've probably noticed, but there's a commercial for a fabric softener, and it's this older couple, and the woman's in the closet and she's trying to get something down from a high shelf, and the husband comes in to help her, and something falls and there's a tussle, and they come out and their clothes are all wrinkled, and the grandson sees them and thinks they've been having fun in the closet in a sexual way and is like horrified and runs away. And
Mm.
um, then they use the downy and they emerge from a closet again, and their clothes are perfectly fine looking, but there's a little wink there that maybe they weren't getting something down from the shelf in the closet at that time.
Nah.
So, okay, so positive in that we're acknowledging older people as sexual beings, right? Negative in the fact that this is the joke of the commercial,
Right.
that, older people are still having sex. So I think we have a long way to go.
Yeah. Yeah.
And
There's a
and
lot
they're
more
just,
jokes.
yeah, I mean, they're just, unfortunately, it seems to be a product of Western culture. So
Mhm.
before we started recording, I was telling you about a project I was doing on older adults with HIV in Africa.
Mhm.
And um, there, that same kind of lack of visibility for older adults. So, like there was one of the older women was complaining that, she goes to the HIV clinic and she has sexual health issues she'd like addressed, but there's nothing there for her because it's also focused on, reproductive health issues for younger
Mhm.
women, and preventing the spread of HIV from mother to child. You know, and so I think we need to do more, but one of the other complaints was that older people in those societies are just not held in the same esteem as they used to be,
Mm.
as their societies become more westernized.
Yeah.
And
Yeah.
you know that means, children disperse, they migrate for economic opportunities. Um, but also that now the older adults in Africa are starting to become invisible like they are here.
Hmm.
And those were societies where those were usually the respected elders and,
Right.
the people who ran things. So I think it's complicated.
Yeah. Well, it's definitely insidious too, I think. And progress and, is often things that are often couched as progress. Then along with that comes a whole trapping of things, as you say, that may dilute some
Mhm.
values that were actually pretty great in places.
Well, not only values, but it's, a real resource that we could use right now.
Yeah. Oh,
There's
yeah.
all this in the talk in the news about the worker shortage. We don't have enough workers, and all these jobs are going unfilled. And at the same time, a lot of people over the age of 50 are being forced into early retirement.
Yeah.
Um,
We have a
and these
ready
are
labor
people that are
force.
healthy, trained, skilled. Older workers tend to have the best work habits. They don't call in sick, they
Yep.
show up,
Sounds
they
pretty
don't sit
good.
around on the job, right? But we can't make that connection.
Yep. Yeah. I mean, this is again one of those things that I think Margaret is illustrative, but really good of policy, right? If there were programs in place that sort of, back to work or reintegrated into work, or were not quotas, because I'm not a big fan of quotas anyway, but things that were put into place in the infrastructure that allowed for that easily, or companies to somehow be incentivized or otherwise to do it, I think that that would be moving the dial, as
Mhm.
opposed to like preaching at CEOs, like if you had a policy, it would happen,
Yeah,
That would be
and there's
good.
some really good pilot projects around that,
Cool.
of reconnecting people to the workforce and reducing age discrimination. Um,
Right.
but that really needs to be embraced like at a state level or a federal
Mm-hmm.
level.
Yep.
Because if you have these scattershot little programs all around, yeah, they're helping some people, but It's not addressing the larger issues that we
Yep.
have.
What are the lessons to be learned that can be universal, like that
Mhm.
we can all apply? Awesome. Well, thank you. I appreciate it, Mark. And I know the students will. They've been hearing my voice only. So it's good to have diversity of thought here. So
Well, my pleasure. Anytime, Maggie.
yes, no problem.